Rob said, so this presentation will give you a brief overview about Candida auris as an organism, but we'll also discuss the importance of Candida auris as a pathogen in a clinical setting. So we'll talk about some general information. We'll go into the symptoms, transmission pathways, and risk factors. We'll touch on antifungal resistance patterns and the current epidemiology, and then discuss current diagnostic methods that are available for use. So Candida auris is a yeast-like fungus that is closely related to Candida albicans and to other Candida species. It was first clinically discovered or described in Japan in 2009 from a woman that had an ear infection, but it was really discovered by chance during a study that was looking at yeast diversity in humans. And then a retrospective analysis was carried out where it was found that the oldest known strain of Candida auris actually dates back to 1996 and was found in South Korea. Since its identification, it has been discovered, or it has spread globally to over 40 different countries worldwide. And it's found in all continents except the Antarctica. Unfortunately, routine screening or testing for this pathogen is still lacking in many parts of the world. And the data that we currently know is almost likely underestimates its actual spread and occurrence in the world. It's predominantly found in healthcare settings and is considered a nosocomial infection. And patients with severe underlying issues or conditions are at most risk to develop a Candida auris infection. And even though Candida auris is most commonly found on the human skin, when causing active disease, bloodstream infections are most frequently reported. Candida auris causes invasive infections and which are related with a high mortality rate of up to 60%. And just in comparison, the mortality rate for an invasive Candida albicans infection is around 40%. Okay, so symptoms, transmission pathways, and risk factors. So Candida auris thrives on the patient's or on human skin, but it can also be found on inanimate surfaces. So it's commonly found in the direct environment of a colonized patient. So for example, on the bed or chair rails, bedside table, door handle, light switch, so all kind of high contact areas. And once it colonizes the patient's skin, the colonization is actually quite persistent and it can go on for many months. And studies have shown that it also can survive on surfaces for up to 1 month. So therefore, transmission is usually through through contaminated surfaces or equipment, but it can also be transmitted through person-to-person contact. Clinical symptoms include ear infections, bloodstream infections, wound infections, but it's also found in respiratory secretions and urine samples. And to mention here is that colonization does not mean infection or disease. And Candida auris is commonly isolated as asymptomatic organism in healthy individuals. So if Candida auris is identified in respiratory samples or urine samples or also on the skin, the question needs to be asked if it's an active infection or just colonization. So common colonization sites are primarily on the skin. So usually samples are taken from the nostrils, groin, axilla, or the rectum as well. And when colonization is present, it's usually in healthy individuals and it does not cause infection and is asymptomatic. However, hand hygiene and environmental cleaning is really important. Candida auris has become very tolerant to many disinfectants and not all disinfectants are active against Candida auris. So therefore, disinfectants that are also active against Clostridium difficile spores are recommended. The most common risk factors to develop an invasive infection are predominantly having a critical underlying issue, staying in a hospital over a long period of time, or being admitted to ICU. and also the overuse of antimicrobials contributes to the risk factors to develop a Candida auris infection. So these risk factors that are listed here are quite similar to other Candida infections, but the mortality rate of invasive Candida auris infections is just much higher than other Candida infections. And as I said before, there's no threat to the general public or to healthy individuals, as Candida auris can be found as commensal on human skin, for example. Okay, so moving on to antifungal resistance patterns, quite an important topic. So just to give you a little bit of background and to put the data into perspective. So there are basically 3 classes of antifungal drugs that are available to use to treat Candida infections. So there's azoles, echinocandins, and amphotericin B. And the problem is that Candida auris is intrinsically resistant to fluconazole, which belongs to the azoles. And this means that it's naturally resistant to this drug without gaining any further genes or mutations. And susceptibility to other treatment agents has also been reported. So this makes Candida auris a multi-drug resistant organism. And there is some data from the United States that suggests that over 90% of isolates are resistant to fluconazole, 30% are resistant to amphotericin B, 40% are resistant to 2 or more classes of antifungals, and 10% are resistant to antifungals overall. So this means that the clinicians are really running out of options because if isolates are resistant to azoles and to amphotericin B, the first line of treatment is usually echinocandins, but resistance to this drug has also been reported. About 5% of isolates are resistant to this drug as well. And to make matters even worse, there's not really a standardized antifungal susceptibility testing for Candida auris that's being kind of implemented in different countries or in different regions. The antifungal susceptibility or the resistance patterns, they vary in different geographical region, depending on which strains are circulating or which drugs are being used. But it can be assumed that this data shown from the United States can be projected to other parts of the world, and that those profiles are reported worldwide. Okay, so this is what the current picture regarding the epidemiology looks like in the world. So this data is from February of this year, so quite recent, from the CDC. And it shows that extensive transmission of Candida auris has occurred in healthcare settings and has been reported worldwide. So this is shown in the pale green and blue marked countries. And there were also cases that have been reported where Candida auris was actually isolated from a patient that had recently stayed in a hospital overseas. So they had stayed in a hospital in a foreign country, and in which also Candida auris cases were documented. So basically what happened was that the patient had imported the pathogen back into the home country. In this case, it was the United States. So if you look at the map, you can see the countries that have these stripy patterns. So that's where the original Candida auris isolate came from and then was imported into the US. So I thought that was quite interesting as well. And then this data shows the current picture in the United States. So it's from December 2020, also from the CDC. And at this time, there were nearly 2,000 Candida auris infections that were reported in the US alone. And asymptomatic colonization was found in over 3,000 patients. So looking at the chart, the numbers are still very low compared to other infectious diseases, but just keeping in mind that Candida auris, it spreads really easily. It's linked to a very high mortality rate, and also the antifungal resistance profiles are very concerning. And then also to think of that this data was generated during the COVID-19 pandemic. So it might not represent the true picture of Candida auris in the United States or in other parts of the world. Yeah, and I also wanted to show you a timeline of an outbreak in a healthcare setting. So this data is from a first hospital outbreak that was reported in the UK. And the outbreak occurred in England in a 20-bed ICU ward in a cardiothoracic center. And a patient was identified to be colonized with, or to have an infection with Candida auris in a wound, from a wound sample. And within 1 week of the first patient being identified, a second patient also became positive, that was in the adjacent bed to the first patient. And the second patient was culture positive at first and then developed an intravascular line related infection caused by Candida auris. So this all happened in April 2015. And then about 2 months later, Candida auris colonization was reported in 2 additional cases. And at that time, environmental screening was performed from different surfaces. So the floors around the bedsides, trolleys, or the equipment was swabbed, and those swabs also came back positive. And then between September and November 2015, 9 cases were reported, and several of those patients also had developed candidemia. And then by January 2016, a total of 50 cases were described in the 16 months period. I know it's not properly readable here, but just to highlight that 50% of patients, it was colonization only, so they didn't develop an active infection or a disease. And then for about 20% of patients, they had candidemia. And then the graph on the right, you can just see the Candida auris cases per month in that healthcare facility during the time of the outbreak. And you can see that, I guess, probably by April or May, the cases are starting to level off. And the healthcare facility, they put in place preventive actions, and also to protocols to combat the outbreak. So they did an intensive screening of the environment and also of high-risk patients to monitor the situation. And then once a patient was tested positive, they were placed in strict isolation, and also all direct contacts were tested. And this particular healthcare facility also implemented a decolonization procedure where they washed the patients with chlorhexidine to kind of get rid of the colonization on the skin. But this was not really reported in other publications, but in this particular outbreak, this was also used. And then thirdly, regular cleaning of the environment and of the equipment was performed with strong chlorine-based cleaning agents, and possibly hydrogen peroxide evaporation was also done. Okay, so the diagnostics that are currently used. So Candida auris can be diagnosed from blood culture samples, from bodily fluids, and from skin swabs. Of course, the rapid diagnostics is important to prevent misidentification or inappropriate treatment. Unfortunately, Candida auris diagnosis is not really routinely performed in most labs, as they might not differentiate Candida on a species level. And environmental swabs can also be used, and they have proven very helpful during outbreak control and to check if your cleaning procedures are really working. There are, I guess, 2 different identification methods that are currently available. So there are the phenotypic methods that do identify and check the antimicrobial susceptibility patterns of the organism. So we have for example, the bioMérieux Vitek platform that's being used, or the MALDI-TOF, so the Bruker MALDI-TOF, for example. The drawback with these systems is that the organism still needs to be cultured and isolated, and a pure isolated culture is needed. So this is time consuming. And then in addition, in previous studies, there were some misidentifications that were reported. So Candida auris was reported as Candida haemollonii, which is a close relative. But this happened because the reference database of these instruments was not updated and didn't include enough data points to actually identify Candida auris. And the gold standard is still molecular diagnostics. So real-time PCR is the gold standard. There is other methods. So there is DNA sequencing that some labs perform, for example, Oxford Nanopore. And DNA sequencing really looks at the genome in more detail to get an idea of, for example, which strains are circulating and to categorize them into different clades, or to check during an outbreak where the outbreak originated from and how the cases are linked together. But that's not often done. It's only done in specialized labs. There are some competing assays on the market. So there are microarrays. For example, GenMark has a panel that targets Candida auris. There's one from BioFire and also from a UTI panel from Courageous as well. And then going back to the real-time PCR, so the CDC has a published protocol online that makes use of primers and probes that were designed by or published by Leach et al. In 2018. And that brings us to our BioGX Candida auris assay for the BD-MAX. So it also utilizes the CDC recommended primers and probe described in that paper, and it targets the ITS2 gene. And sample types that are compatible are respiratory samples, so pre-treated sputum and bile samples, urine samples, various swab samples from wounds or skin swabs, but also from the environment. So as you all know, the PCR reagents are provided in sample-ready lyophilized format. 1 kit is enough to test 24 patient or 24 samples. It is used with the BD extraction kit DNA3, and the time to result is less than 2 hours. And I'm sure you're all familiar with the workflow of the BD-MAX and how to use this assay, but just kind of briefly to touch on how the workflow of this assay, what it looks like. So the customer needs the BD extraction strips and also BD PCR cartridges. And those extraction strips are loaded onto the rack, and then the BioGX reagents are snapped into the extraction strips. Then the sample is added to the sample buffer tube, which also comes with the extraction strip. And once that's done, the sample racks are loaded onto the BD-MAX. And then the PCR cartridge is also loaded onto the instrument, and then the run can start. So yeah, so that's it. So I hope it gave you a good overview about Candida auris itself, and just made you aware of this emerging pathogen that we will probably hear from in the future as well. So yeah, if you have any questions, just let us know.